Blue Cross and Blue Shield of North Carolina is excited to share with you today the results from our groundbreaking food delivery and health coaching model test. Blue Cross NC is committed to addressing the non-medical factors that impact health, like food security, through a rigorous research and development approach. Today, we have a panel of amazing experts that will talk through this model test and help us to learn more about the results that we have learned. First, we have Dr. John Lumpkin, the Executive Strategic Counselor for Marketing and Corporate Social Responsibility. We have Lori Taylor, our Program Lead in Drivers of Health Strategy for our Test and Learn models. Vanessa Green, our Analytics Manager for Information Technology. Madison Taylor, a Senior Analyst in our Actuarial Services. And Dr. Jennifer Yadley, the Health Economist for Drivers of Health Strategy. Let's talk about how things will go today. First, we're going to talk about why. Why does Blue Cross NC have such a commitment to the non-medical factors that impact health? And then we're going to talk about how. How have we put together a team to address these factors and to do research to determine how best to impact them? We'll dig into the implementation. How did we make this model happen? How did we get these amazing results through many steps that took us to the final result? And then why it matters. What are we going to do with the results? How might you use them? How might they impact your work in your day-to-day life? And then, most exciting, we're going to talk about what's next for Blue Cross NC and this amazing work. Dr. Lumpkin, can you educate us on what we mean by the term drivers of health and why Blue Cross NC as a payer has prioritized addressing them?
Well, think about it in this context. There are over 500,000 minutes in each year. And of those 500,000 minutes, the average person spends only about 1 hour in a clinical setting. Health happens where people live, where they work, and where they play. These are where the non-clinical factors that influence health occur. That is why we call these and talk about them in the context of drivers of health. Now, let me tell you a little bit about Blue Cross Blue Shield North Carolina, sort of how we got into this. Our mission is to improve the health and well-being of our customers and community. And then we go further to say that we will not stop until healthcare is better for all. And that guides our thinking about how we address the clinical needs, but to go further and address these non-clinical factors that influence our members and the communities where they live. So when we think about accomplishing our mission to improve the health and well-being, we recognize that we have to address these non-clinical factors, these drivers of health. Looking at our members, when we look at the data, it really is dramatic. 20% of our members, all of our members, exclusive of Medicaid, are predicted to be food insecure. 1 out of 3 of our members with diabetes are predicted to be food insecure. 1 out of 3 of our members with behavioral health challenges. And then when we look at the impact of those who are predicted to be food insecure amongst our membership, almost half of those, 48% more emergency department visits than our food secure members. And the data continues. 1 out of 7 of our total membership live in a food desert. And about 20% of those are predicted to be food insecure. And the impact is real. Not only does it have an impact on health outcomes, but it also has an impact on cost. And we estimate that there's about a $45 million annual cost to those increased emergency department visits. And now turning to this chart that you can see on this slide. We have 2 lines. Those members who are living in a food desert and those members who don't. And we looked at 60,000 commercial members. These are members who get their health insurance through their employer. And for every single one of the years from when they started in the health plan in 2016, through that 5-year period of time, in every single one of those years, the members who lived in food deserts had average higher costs than those who did not. And when you total those costs through the 5-year period of time, the difference for the 9,700 members was $23 million. These are real costs. These are costs that otherwise could be used to provide other services or reduce premiums. So when we think about these costs, they are directly associated with members who are food insecure and members who live in a food desert. However, you can't make a business case because of predicted costs. We have to look at what the interventions are. And let me give a quick example on that. Every one of our members is getting older. And we know getting older is associated with higher healthcare costs. You can't make the business case for getting people younger because there isn't an intervention. But we believe that we can have interventions related to addressing drivers of health. And if we do that, we can improve health outcomes, we can have exceptional experience for our members, and we can lower healthcare costs. And because our mission is to improve the health and well-being for everyone, to not stop until healthcare is better for all, we recognize the importance of playing a leadership role to take our innovation and to share it with all of you so that other organizations can begin to implement the kinds of innovations that we're developing here at Blue Cross. The critical part of that was pulling together a team. And it was involved with first commitment across the organization, starting off with the leadership, developing a dedicated drivers of health team, which you'll hear from today, having an analytics partner who can help us with looking at the data and then going further into costing it out through actuary, and then to move in and engage stakeholders across the company. And when we did that, we find we could implement these test and learn models of drivers of health interventions, analyze them, get the data, and begin to share it. And you'll hear more about that.
Lori, let's get into the nitty-gritty of the food delivery and health coaching model. Can you talk us through, since you were there from inception to the final results, can you talk us through the implementation of this model?
I am so happy to do so, Kim. As Dr. Lumpkin shared, this team was formed in 2020 as a research and development team. So we wanted to build the quantifiable evidence in our own members. We identified food insecurity as the #1 unmet need in the nation. And with that, working with our wonderful analytic partners, we also identified that diabetes was one of the most prevalent conditions and the most expensive for our members. So we wanted to look at an intervention that could address both. We were introduced to our vendor partner, Pack Health. They are a wonderful digital coaching solution to manage chronic conditions. Remember, this was during 2020. It was the pandemic. And what they did was provide food boxes to their clients. We had this wonderful idea to combine the two. So we went to PAC and said, could you do this? Could we create a program to bring individuals who were diagnosed with type 2 diabetes, who were food insecure, healthy food coupled with health coaching that you're so good at? And this idea was born. As Dr. Lumpkin shared with our data, we often think about the need being in the Medicaid or uninsured, and we tested this model in our commercial population. It was designed to supplement groceries with 2 healthy boxes per month. The vendor leaned in and co-designed these boxes with us, along with easy to make recipes that people thinking through what they have in their own kitchen so it wouldn't be cumbersome. We designed and launched this quickly. We were a new team and we wanted to help our members who needed it most. So we developed this in just 3 months, Kim. That's unheard of. And we launched in late Q4 2020, first with our social work and care managers to screen. They're working with our members, they're screening them for food insecurity, and we gave them an intervention to help our members. Then in early 2021, we launched a marketing engagement campaign, and we had to think about what did this campaign look like, even to the creative of having masks on the images, on the emails, so people felt comfortable. The food was being delivered to home, which also helped them feel comfortable. The response was overwhelming, and we hit our enrollment goal early.
Lori, that's an amazing implementation story, and it was so exciting for us in the moment when we were doing it. But let's dig in even a little more deeply. Let's talk about the population. And this is where our data and analytics come in. How did we leverage data to identify who would participate in the model?
Thank you for that question, Kim. We could not do this work without our amazing data and analytic partners. They're critical to the success, from identifying the population as we did, looking at food insecurity as well as diagnosis of type 2 diabetes, and then developing KPIs and metrics so we could build that quantifiable evidence. How many people did we help? What did our engagement look like? What did our enrollment look like? What did our participants look like? We wanted to understand the demographics, where they lived. Was it rural versus urban? Were they food deserts versus non-food deserts? Looking at the outcomes that matter, the impact on food insecurity, improving their mental and physical health, their satisfaction with this program. Is this something they want and their experience? And last but not least, we also looking at that medical expense that Dr. Lumpkin highlighted, because what that results in is driving affordability for our members.
Dr. Lumpkin talked about leadership and innovation. Where did this idea come from, Lori?
Thank you for that question, Kim. As a research and development function, we spent a lot of time looking at the literature, looking at what's out there. And Geisinger was groundbreaking in 2016 in the clinical space, launching a fresh food pharmacy for their patients living with type 2 diabetes and using their clinical staff to provide that education. We thought, what if we did this as a proof of concept from a payer lens and building that evidence within our own member population and identifying that need and evaluating the results.
Vanessa, we've heard so many lead-ins about data and analytics so far today. So can you talk to us about the pivotal role that data and analytics plays in the success of this model and creating this evidence, measuring these key performance indicators or these KPIs as we move through the model?
Sure. Thanks, Kim. I would consider data and analytics really to be a foundational capability for ensuring that we are able to assess this evidence-based work. Really, in order to do effective analysis, it really first starts with the data. So we have a team of data engineers who are wonderful, who really go through and ensure that we have curated data that the analytics professionals can then access and utilize for effective analysis. And some of the analysis that we put in place are opportunity analysis. So Lori talked about that earlier, where we're identifying a population that we can analyze and assess and determine if they would benefit from this intervention. We also identify the population that's eligible once the test and learn model is underway. And then we go through monitoring. So we use analytics to monitor that population when they're actually matriculating through the test and learn models. And then lastly, we do evaluations. Jennifer will talk about this in more detail, but our team actually does statistical evaluations to assess the efficacy of the test and learn models that are underway. And so that was done for the food delivery and healthy coaching pilot. And that work was then used by the actuarial teams to then transition this into a program that it can be offered to our broader member base.
We know that our members are always first, but as Dr. Lumpkin talked about at the beginning of the event today, besides health outcomes for our members, it's also important for us to evaluate the work. That's a huge priority. I'm going to lean now to Dr. Jennifer Yedley to tell us a little bit about the evaluation process and then talk through it for food delivery and health coaching.
Sure. This evaluation had two main components. First, there was a formative evaluation component. And through a formative evaluation, we seek to assess whether the program was implemented with fidelity. In other words, did we implement the program as intended? Did it meet the expectations of the model? The second component is an outcome evaluation. This was designed as a pre-post design in which we compare members who participated in the program to members who are outreached to but elect not to participate. The focus of an outcome evaluation is really on the impact of participation on those health outcomes that were discussed earlier, engagement and experience in and with the program, and growth. Does participation impact members' willingness to continue with Blue Cross, and does it encourage and invite non-members to become members? And lastly, of course, does participation in a program like this impact the cost of care? Now, the setting that we work in is a little bit different than what you would see in an academic setting. Quality improvement is really the focus of this kind of evaluation work. The aim is to improve programs or develop quality, effective programs and benefits to be offered directly to our members. In an academic setting, the aim is to develop interventions that are effective, but really geared towards establishing and writing the scientific evidence in the literature. And secondly, it's about feasibility and impact. Can we as a payer practically do this work and improve the outcomes of our members? One of the things that I think people latch on to is the rigor. Are we able to evaluate programs as a payer with the same rigor that's expected in the scientific field? We do. With our data and analytics partners, the quality of the data that we have access to and that we also collect, we can use the methods of evaluation and statistics to adjust for things like bias because we don't do randomization.
Jennifer, thank you for grounding us and sharing that foundational knowledge. Let's get into the results. Tell us a little bit about what we saw in the evaluation for food delivery and health coaching.
Absolutely, Kim. This is an exciting program, which the results were beyond, I think, expectation. For the formative part of it, we were able to observe variation in participation among members. Some members participated for 1 month, others for the full 6 months of the program. Second, participation was primarily impacted by disinterest in the program, or the program wasn't what members expected it to be when they first enrolled. As the program progressed, as we learned through our experience, we were able to make several adaptations. This is not something you see in traditional research circles, but here in our environment, the idea is to really test and learn about what we're doing to develop the most effective program possible. For example, the initial food vendor that was contracted to deliver the food to members, there were some issues and concerns with the delivery. We pivoted midstream and were able to identify an additional vendor who could support our members with the food delivery. Health outcomes, when we come to the impact portion of an evaluation, we observed improvements in the rates of obesity and, very importantly, in the management of members' HbA1c levels. We surveyed members at a time of enrollment and also 6 months after participating in the program and observed improvements in their self-rated physical and mental health status. The rate of food insecurity decreased by 20%. Members were enrolled at a much higher rate than what we normally see in programs offered, and engagement was very high. 77% of those members who enrolled in the program engaged fully in the program. Almost all of the members who participated reported to us at 6 months that they expected to renew their policy with Blue Cross because of their participation in the program. Their experience was so satisfying that they wanted to stay Blue. And growth. 44% of the people who participated in the program, Kim, expect a benefit like this from their health insurer. I don't know about you, but that was surprising to me. Individuals who are concerned about their health are seeking these kinds of programs. And lastly, but not least, of course, impact on costs. On average, members who participated for the full 6 months of the program experienced a $147 decrease per month in their total cost of care. We also observed an increase in pharmacy costs. That's not necessarily a bad thing. If members are able to afford medications that they should be taking because they're able to provide food for themselves and their families, that's a good thing.
So we shared that this was one of our very early test and learn models for Blue Cross North Carolina's Drivers of Health strategy. And along the way, there were many lessons that we learned. But I want to turn to Lori, who led the implementation here. Share with us one of the major lessons that you learned throughout this model test, Lori.
Kim, great question. We wouldn't be a research and development function if we didn't have those lessons learned. It's a test and learn model, right? One of the biggest challenges was identifying individuals who are food insecure. We didn't have social needs screening data, screening for food insecurity, but we needed to identify that population. As a group and with our analytic partners, we came together and said, what if we use federal poverty level as a proxy for food insecurity? And we did, and that's how we identified the population combined with diagnosis of type 2 diabetes. However, we learned that income may not be the best indicator, as 41% of the individuals who participated in the food delivery and health coaching model tests screened positive for food insecurity at baseline. We also know that individual social needs change over time, thus self-reported data is the gold standard.
So we talked about tons of lessons learned along the way, not just for implementation, but for data and analytics. Vanessa, share with us from that perspective some of the lessons that you learned along the way.
Yeah, we learned several. Data and analytics, the very first and probably a core lesson is that data and analytics in this space really requires innovation, because you're using non-standard data sources that are not typical within a healthcare setting. So we partnered with our strategy partners to really identify good data sources to really ingest and analyze to help us understand this test and learn model and what was happening with the members that were matriculating through it. Secondly, the definition of success had to evolve. Within most companies, the definition of success is really related to cost savings. But within this environment, we're really trying to measure a broader, deeper definition of success. And really that comes down to health outcomes, better member engagement, better member experience. And then on top of that, we do want to see positive changes in medical expense. And those positive changes could be an increase because they're utilizing the health systems more, but we still would consider that to be a positive change. So success had to be defined differently. Thirdly, when you really think about test and learn models, less successful test and learn models, this one is not a great example of that because I would consider this to be a really successful test and learn model. But if you do have one that's less successful, that's still success because you still learn something through this process. As Lori and Dr. Lumpkin and others have mentioned, this is a research and development function. So everything is not going to be perfect. And so the ones that are less perfect, you still have a great learning opportunity and an opportunity to educate the industry on what works and what doesn't work with these populations of people. Lastly, effectively addressing DOH issues really requires diversity of thoughts and skills. So you can see on this panel, all of us bring forth a different skill set, which is required to really effectively understand and address the needs of these members.
At the top of the hour, Dr. Lumpkin talked about all of the team that we put together for the success of this model. And Vanessa gave us a perfect segue talking about the different skill sets that are needed. We look to you now, Madison. When we finally have results from a model, we look to our partners in actuary to help us to move those results to productization. Can you educate us a little bit about that process?
Yes, so overall, Blue Cross Blue Shield of North Carolina has a large portfolio of savings initiatives, and food delivery and health coaching is one of those that will generate savings, contributing to that overall savings number, and then eventually which leads into rates. So the savings estimate for food delivery and health coaching can be differentiated from some of our other initiatives that we work on because instead of predicting member behaviors largely based on assumptions, we are able to use the true member experience from the pilot program. So the savings estimate here, normally with new programs, we're looking at historical claims, utilization, et cetera. But here the pilot results really speak for themselves. The program does have higher costs compared to some of our other initiatives, just given the nature of the program since we are delivering food. But even with these higher costs, through our actuarial modeling, there are still meaningful savings on the bottom line claims. Now from a pricing perspective, I'll highlight 3 of the main adjustments and assumptions that we used in our modeling. So the first adjustment was a demographic adjustment. Food delivery and health coaching is going to impact different groups in different ways. And since there are multiple groups impacted, each with different and constantly changing compositions, when we're looking at projecting any savings, we need to make sure to account for these differences in the populations. So specifically, the savings generated from the pilot program have to be on a basis that's applicable to the other eligible groups. Amongst other factors, claims experience, utilization, cost, et cetera, really vary based on the age and the gender of the member. So in order to account for any potential differences in how the savings would impact different groups, we relied on historical data of our members and compared this between the groups. The next assumption that I'll run through is a turnover assumption. So some members are going to participate in the program and then move on to other health plans. In these cases, we still do see savings generated. However, we do lose those long-lasting benefits that food delivery and health coaching is projected to provide. So in order to account for that, we used a turnover assumption in our modeling. We do see a potential for improved persistency, like Jennifer ran through a little bit earlier, due to the fact that we think members will highly value this benefit. So we think it could encourage them to want to stay on the plan for longer. The last assumption that I'll highlight is a new member assumption. So we looked at the turnover, now thinking about potential for new members. When a new member joins the program, it's an opportunity for additional savings to be generated due to the better health and habits of the new member. So we did want to include an assumption around new engagements in subsequent years to really capture the impact that the improved health would have on overall savings. So now from a savings perspective, we know that there's an initial savings estimate per member enrolled based on the results of the pilot. We also want to make sure that we capture any incremental savings. So for example, first year versus second year, we're counting on the second year having some level of additional savings due to the continued success of the program and thus continued improvement in health of our members. We wouldn't necessarily expect the same level of improvement year over year, but at the very least, the theory would be that the continued claim savings are based on someone that graduated from the program and continued to live a healthy life. So lastly, once the program's in place and we have a valid experience period, enough time for the claims to develop, we move to the performance tracking portion. And this involves continuously updating our projections as well as assumption monitoring. So we're looking at the assumptions that I just ran through as well as others, seeing how they come in based on expected and adjusting our projections accordingly. We do expect the impact of this program to be evident through claims experience. However, this is a unique and new program, so we do expect that we might have to implement some new methodologies in order to truly capture the full impact of the program.
Dr. Lumpkin, you led us off and said that Blue Cross NC will not stop until healthcare is better for all. Our panelists shared all about the food delivery and health coaching model and what we've seen, but that's not all. What's next for Blue Cross NC?
Well, I've just been with Blue Cross now almost 4 years, my first venture in health insurance. And the complexity of what it means to bring something like this and then to have it implemented in all the programs of Blue Cross is something that completely surprised me. So our first step is to take the experiences from food delivery, health coaching, and to move it into our different product lines. Now, originally I thought, okay, that makes sense. Madison did through all the analysis, and Vanessa, we know what the numbers are. But then you have to understand that each of these programs have their own characteristics. How you go about in a commercial program where employers are implemented, either directly because they're completely buying it all from Blue Cross, or Blue Cross is administering the program for them and they're bearing the risk. the program design is totally different. So we're going to be moving this into our different product lines. We're going to move into a couple in 2024 and then across all of our product lines by 2025. What you're seeing today, what we talked about today, is, as Lori mentioned, an initiative that began in 2020. It's 3 years in development. We have other products that are also developing. Falls prevention. We've looked at some other issues related to social isolation. How do we better deliver our programs to our members related to food? So we're going to continue to do test and learn to develop other products. And then we have to look at some of the challenges in implementation. In many of our communities across North Carolina, nonprofits, community-based organizations are part of the economic infrastructure of communities that historically have not had as much investment as other communities. And so we're looking at ways that we can better engage nonprofits in delivering these services to our members. And then finally, we talked about our purpose. Our purpose to improve the health and well-being for our members and community. We won't stop until healthcare is better for all. And that means that we think about how we share what we're doing. Part of it is the publication that we had in the New England Journal of Medicine in the Catalyst section. Another part is this webinar and joining with you to share what we've learned. But we'll continue to work because what we do will make things better for our members and better for their communities, because we won't stop until healthcare is better for all.
We know that this information has made you as excited about this work as we are. We continue to remain curious, and we're sure that you are as well. So we're going to take some questions and provide some more answers for you. Please don't forget to fill out the survey related to the information that we've shared today so that we know how we can be more informative when we share about our future work. Let's take some questions. So, Lori, we've heard some questions around the criteria for determining food insecurity. Can you tell us a little bit about how we make those determinations in general, and then maybe how we did it specifically for the food delivery and health coaching model?
Absolutely, Kim. In identifying food insecurity, the gold standard is social needs screening data. However, that data is lacking across the country, and we have actually stepped up and have launched a screen and refer strategy so that we can better understand our members' ongoing needs. But in terms of the pilot, we use federal poverty level, in this case, of 100 to 150%. Again, this was back in 2020, and we have 40-year high inflation rates. So it doesn't really replicate that ongoing need. And so integrating those data points are relevant and important to identifying the need of the population. Brian, I'd love for you to share more on how our analytics partners are doing just that.
Absolutely. One of the things that we're really excited about in the future as we look towards how we're going to leverage our data to better understand, better identify the members who are impacted by these kinds of problems is these test and learn models and the data that comes out of that. We have survey data that specifically identifies individuals who identify with food insecurity. We can then use that data to actually build models that interpolate whether or not that others in the population have those, and then be able to respond with programs appropriately.
Brian Snavy, we're so glad to have you here with us today. And we'd love to hear a little bit more, because you've been along this journey with us, the data and analytics team. How are we evolving our data and analytics to be more innovative for the future?
Absolutely. When I think of our strategy to evolve our analytics, it really falls into kind of three pillars. The first is really modernizing our infrastructure. The future of data and analytics, particularly in this space, is the ability to work more closely with partners, be they providers or community groups or even governmental institutions. Our ability to integrate with them as seamlessly as possible, as quickly as possible, is paramount to be able to deliver on these kind of programs in the future. The second is really leveraging some of these more advanced statistical models, even getting into the AI/ML space. That allows us to better understand who's going to best benefit from these programs. No margin, no mission. We have to make sure that we target the right people so that we can deliver the value that we need to deliver and see what we need to see as a company: improvement in quality, improvement in cost, just in line with our evaluations. The third pillar really is that community partnership. When I think about what we're doing to work with our providers with the Blue Premier program, getting the EHR back, getting the EMR back, advancing our data collection techniques, the self-identified surveys that we're getting information in, those are really critical steps for us from a data acquisition perspective to be able to leverage to get these kind of programs out the door.
Awesome, thank you. So, Lori, you've talked about how you watched this process start from the beginning all the way to these amazing results. Knowing what you know now, what are some of the key elements that are vital for a food intervention program?
Thank you, Kim. I think at the foremost, it is health equity. We need to provide people with choice and agency, meeting them where they're at, providing food interventions that meet their cultural and other preferences, dietary preferences, looking at what they have in the home to prepare the food, taking that through that journey while providing one-on-one nutritional and coaching support to drive sustained behavioral change. That is truly the essence of food as medicine. And I'm so excited because we're not alone in this endeavor. The industry is just widening from the White House commitment to ending hunger to our industry partners to policymakers. It's an exciting time, and we're in this together. Our CEO at Blue Cross North Carolina always says we are stronger when we have the coalition of the willing, and we do, and we will make an impact for the population at large.
Awesome. How important was that coaching element?
Critical. When you think about living with type 2 diabetes, and I am a daughter of two parents who did, and driving behavioral change is hard. It's really hard. Living with diabetes is a very difficult disease. And when I say meeting people where they're at, using coaching, using motivational interviewing, helping that individual set goals that are important to them, enables them to be a partner in their care.
Now, Jennifer, I have a similar question for you. She talked about some of the vital elements when we think about creating a food delivery intervention or program. When you are evaluating those programs, what are the vital elements that our viewers may be interested in hearing about?
I think first and foremost, data. Quality, valid data is critical to being able to assess the impact of any program. And so working with Brian and his team and others in our data groups, it's critical to understand what data we have access to, what data we don't have access to, and if we don't have access, what is at least a good proxy for those pieces of data or impacts and outcomes that we want to understand. Second, I think it's not a specific component, but it's more of a general approach or an attitude towards the work that we do. We need to be flexible, we need to be nimble, and we need to not be afraid of adapting as we go. We are doing this in the real world. We're getting feedback from participants, from our partner vendors, and how the program's being implemented. And in order to evaluate what actually happened, we need to create a feedback loop where we're taking those learnings while we're evaluating and implementing the program at the same time and adjust the evaluation to account for those sometimes surprises in the implementation of a particular program.
Thanks. So, one of our goals through our advocacy and thought leadership at Blue Cross NC is to share our learning so that they can be replicated by others. So, Lori, we have tons of questions still around the model test that you conducted. Tell us a little bit about vendor selection, how you went about this process, and what you've learned along the way.
Thank you, Kim. Vendor selection is critical. There are incredible vendors out there doing wonderful work, but they're not all the same. And for us to have the data to evaluate, we need a strong vendor who has incredible data elements and capabilities. We need a vendor who can lean in through the test and learn approach, right? We have to take an agile mindset, and as we evaluate along the way, if something's not working, we need to be able to pivot. And a vendor who's not cookie cutter and can do just that is critical. And lastly, having clinical data is key to evaluating the impact on outcomes. Patient-reported outcomes are important, but that clinical data along with medical expense reduction really demonstrates that the results that we're looking to achieve.
So, Dr. Lumpkin, this is an area that's near and dear to your heart. We received a question around how we're partnering with community-based organizations. And we know that they have similar goals. We don't want to disrupt that work, or we don't want to put an undue stressor on them. But how are we looking to work with them more in the future?
Well, community organizations are critical to the life and vigor of communities. And so we think about that because, as I mentioned before, our mission is to improve the health and well-being of our customers and community. At the same time, we have a commitment to our members. When someone has diabetes and we're trying to do an intervention that will impact them, that will improve their health, that will improve their outcomes and help them control their diabetes, we need to make sure that the food box is there, that the coaching is available when the member needs it. There are many nonprofits throughout North Carolina who can meet those needs. In a way, it sort of gets to the issue of the vendor. Mm-hmm. We're looking, as we think about moving this program into production, we want a vendor who will be thinking about a for-profit, not-for-profit solution to being able to deliver food and have the interventions. But we want to go further. We recognize that the current mechanisms that's in place for engaging nonprofits is we tell nonprofits, you have to become part of the medical institutions. You have to submit bills. You have to arbitrate bills. And I'm sorry, if I'm working in a food pantry, I'm there because I want to help people who are hungry. That's right. We need to come halfway. And those are the kinds of things that we're exploring as we think about the models. We'll initiate with a vendor partner, and we'll look for ways increasingly as we build out these programs to partner with nonprofits in ways that doesn't raise their administrative costs, but enables them to carry out their mission to address hunger and food insecurity in a way that will also benefit our members.
Thanks, John. So we've talked about our food delivery health coaching model. That's what we've been sharing today. But Lori, you lead all of our model tests for the Drivers of Health strategy team. Tell us a little bit about some additional pilots that we've done to address some other drivers. And when we talk about drivers of health, we're talking about non-medical factors that impact health, and food is one of them, but there are others.
That's right, Kim. How much time do we have left? You know, running pilots is in our DNA as a research and development function. And I'm really proud of the work that we've done in a very short period of time. Again, we've only been around since 2020. Kim actually led an incredible intervention to address social isolation and loneliness. We've also tested healthy housing. How can that home environment and modifications, education, and support reduce falls and those downstream impacts on morbidity and mortality? We've run several food interventions, and they are not all the same. And really, that has informed us that we need to have a menu of options. We've run produce prescription programs, FNS SNAP application support. We're running a randomized clinical trial with our partners at UNC Sheps. We are working with nonprofits and supporting them in the work they're already doing through a CBO capitation payment model. And we're continuing to evaluate the need in our members so we can identify new interventions to test and learn from so that we can inform the business to bring forth as programs and benefits.
Madison, You shared with us the actuarial process and you broke it down so that all of us could understand kind of how you partnered with the Drivers of Health strategy team when evaluating this model test. Could you share, though, with our audience, again, trying to share our thought leadership here, how we replicate this, how we share what we've learned? Why is it so important for you, our actuarial partners, to be a part of this process with us?
Well, I would say that it's important from an actuarial perspective. When we're looking at the results of the pilot program, we are actually able to see the real results as far as what, how we would expect a program like this to actually progress. So when we think about it from an actuarial perspective, we're making a lot of assumptions in a lot of different ways. The nice thing about this pilot program was that we were able to rely on the actual results that we saw. So as actuaries, we're trying to predict the future. The great thing about this program and others is that we really have great evidence that going forward, we know it's going to perform very well.
That's awesome. Thank you for sharing. And then, Dr. Lumpkin, when we think about food as medicine, we hear so much about that now. Let's look at food as medicine and then also think for the future as far as Blue Cross NC and addressing drivers of health. Can you kind of help cast a vision for us of where we're looking to move in the future?
You know, we've done through this study, we've demonstrated that you can have impact doing an intervention of food delivery, health coaching intervention. What is critical about the work that we've done is that we've pulled together a team. It's a team of those on the Drivers of Health team, our analytics partners, working with actuaries. But what you don't see here are the other members of the Blue Cross team. We have a large number of lines of business. We have our Medicare business, we have our Medicaid business, we have commercial, we have a business, an ASO business, where we work with large companies across the country. And in each one of these lines of business, how we implement something like this is different, and how we pay for it is different. So the critical part of our partnership is taking what I have in a long career in public health have always believed, that if you do interventions, it will cut costs. That's not enough for medicine to go on. But if we can do studies like this, and others who are in the audience can follow the same model, we begin to create the business evidence. So not only is it the right thing to do, but it's also the right business thing to do. Because every organization that's involved in healthcare is thinking about how they can have better results for their members, for their patients. Now, as our nation is moving forward, we're beginning to get an understanding about how important food is. Just 2 days ago, there was an article that showed that in a twin study, that if a twin had a vegan diet and one was on an omnivore diet, that if they followed them over a period of time, the one that was on the diet actually had lower risk for heart disease. We're looking at ways that what we eat impacts our gut microbiome. Food impacts our health. And for those who don't have access to healthy food, we can begin to do the interventions that lead to good outcomes. So making food as medicine, not only a part of what we do at Blue Cross of North Carolina, but what every health insurer does across the country, is where I see the future of food as medicine. That it becomes the right thing to do and the right business thing to do.
As we get ready to wrap up today, we are so excited that you all have joined us, and we thank you for being a part of us sharing the results from this webinar. If you're looking for the results, they are published in our article in the New England Journal of Medicine, and we'll be happy to share that. And this webinar will be available for all of you who have attended, as well as for anyone else who wants to visit and take a look at the production. Again, we thank you. But before we go, Dr. Lumpkin, can you just wrap us up talking about Drivers of Health and the Blue Cross mission and purpose?
Thank you, Kim. And also thank you to the rest of the panel, not only just for being here today, but the fact that being able to do this kind of work, as I mentioned before, we've all talked about, really takes a dynamic team, a committed team. And that's what we're about at Blue Cross of North Carolina. Our mission, our purpose, is to improve the health and well-being of our members and community. And we won't stop until health is better for all. Now, having a mission like that, having a purpose like that, is not incompatible with our business. And that is really where we're trying to send a message that addressing food as medicine is the right thing to do. It's the business right thing to do. But it's not just food. Lori talked about some of the interventions that we're in the process of, thinking about falls prevention, thinking about another topic we've looked at, which is addressing loneliness and social isolation, transportation, housing. All of these are factors. And we have to recognize that we can't just look at what happens in a clinical setting. Just to put it in context, on average, a person in this country spends 60 minutes a year in a clinical setting. And there are 500,000 minutes in that year. 60 out of 500,000 in the clinical setting. Health happens where people live, where they work, and where they play. And if we're in the health business, which we are, and we're committed to the health of our members and community, then we have to pay attention to these non-clinical factors.
Thank you. Thank you all for joining us. Please feel free to reach out to our team if there are any additional questions that you would like to share with us. Thank you.